welcome everybody. We're going to get started in just a few seconds. Feel free to type in the chat box, share where you're joining us or zooming in from tonight. Usually I would say sunny San Diego, but it's been extremely windy, so it feels a little bit more like Chicago. Cool, we got some calling in from Brazil and Portugal and Mexico City, so our friends from the South. All right. Well, we're glad to see everybody tonight. We're going to ask you to turn off your video unless you're one of the presenters or discussants. But please feel free to type in the chat box, A, where you're from, and B, any questions. So tonight we're excited to be back. This is the ATS COVID-19 Critical Care Training Forum. We went several months last year putting these forums on every Tuesday night from 8 to 9 p.m. Eastern Time. This is the first one in 2021, and we're going to focus it really as a discussion to answer some questions. Maybe we're going to ask more questions than we answer. So I'll be moderating the session tonight, and we have several fantastic experts who will be joining and speaking with us. So Dr. Robert Owens from UCSD, who I get to work with on a regular basis. And we have one of our stellar fellows, William Cameron McGuire. And then Dr. Nirav Shah is joining from University of Maryland, Dr. Viren Kaul from Crouse Hospital in SUNY Upstate. We have Dr. Isabel Pedraza from Cedars-Sinai, and we're hoping that a little bit later, Dr. Christine Bojanowski from Tulane will be joining us. As I mentioned, we recorded 27 sessions last year throughout the pandemic. All of these sessions are available for free on the ATS website. If you Google ATS COVID Forum, it'll take you right there, and we'll post this link in the chat box as well. But feel free to check out that content. This wouldn't be possible without several people working hard together to get these forums done, but in particular the ATS staff, including Lauren Lynch, Liz Guzman, and Eileen Larson have been big drivers. And a big shout out to Rebecca, who used to be very helpful, but I've just heard that she started graduate school. So as we get started tonight, if you could share in the chat box where you're joining us from, and we will be posting a survey for you to fill out. And this survey is more for us to just know who's joining, and we would love to hear your thoughts on what we should try and cover in the upcoming forums. So through that survey, you'll be able to type in your suggestions for topics. So tonight, if you would, please share in the chat box, what questions do you have about caring for critically ill patients? Are there some new conundrums out there, or have you been doing a certain thing for months and now are wondering, is that still the right thing to be doing? That's what we're here to work on tonight. Some examples include proning. Should we be discharging patients home on oxygen as some hospitals are full and have no options? Is this a safe practice? When to DC COVID precautions? What antivirals or anti-inflammatories work? Which ones don't? High flow oxygen, is that safe to use versus intubation? And any anticoagulation updates. So I'm going to stop sharing my screen there, since really the focus tonight is on discussion and sharing best practices. I see lots of people sharing their locations, so wow, and it snowed in Las Vegas. Awesome. So with that, while you guys are thinking about your questions and sharing them in the chat box, we thought we'd start off with having Dr. McGuire go ahead and do a short presentation on proning to sort of get us up to date on where we are with this practice. And so while he's doing that, if you would type your questions into the chat box, and we'll dive right in on what you guys want to cover tonight. So Dr. McGuire, take it away.
Great, thanks, Dr. Crotty Alexander. I'm going to share my screen here. Can everyone let me know if you can see my PowerPoint?
Yes.
All right, great. So again, I'm going to do a brief primer on the prone position in severe and moderate ARDS. Disclaimer, this will be focusing on patients who are ill enough to be in the intensive care unit, typically on mechanical ventilation. But before we start, just a quick question, and if everyone could post an answer in the chat box to the following slide. Which of the following papers is the seminal prone position study we typically reference in the ICU? And here are your 5 choices. You can put 1, 2, 3, 4, 5, or A, B, C, D, E if you'd like. If we could just get a quick sort of assessment in the chat box of what people think. I'll just wait a few seconds since we have lots of expert discussants to discuss this and many other topics today.
People are feeling a little bit quiet tonight, but
I'm seeing that.
They're starting to come in.
Don't worry, this isn't graded.
It would be pretty funny if one of the authors was on and voted for themselves.
Yeah, I kind of wonder. Maybe number 2 has the most likelihood of authors being tuned in. All right, great. So it looks like there's a great smattering of answers. I've seen at least one answer for each option. Feel free to let them keep trickling in, but I'm going to go ahead and move forward. So the correct answer for the seminal prone position study that we typically reference in the ICU is option C, or option 3. So Claude Guerin et al., New England Journal of Medicine, 2013. This is the PROSEVA study, or the seminal study in prone therapy. All of the rest of these trials, though, are really important trials in the management of ARDS. And just to quickly close the loop as a teaching point on each of these trials and why they're relevant, the Brauer Trial from 2000 is the ARMA trial that gave us low tidal volume ventilation for ARDS. The Wiedemann et al. Trial gave us the FACT trial, which is where we kind of developed that concept of a dry lung as a happy lung, for what that's worth, where we typically aim for a negative volume status or at least euvolemia in patients with severe ARDS. The Papazian et al. Trial from 2010 was the initial paralytic trial called AccuraSys that has since been revisited by the Rose trial, but we won't go into that today. And then last but not least, Combs et al. Is the Eolia trial. It's actually the second ECMO trial in severe ARDS, with the Cesar trial being the first, but this is the one that maybe showed a suggestion of benefit using ECMO early in severe ARDS. I'm not going to go into those trials at all, but just know that these are all some great requisite reading for those of you who are taking care of severe ARDS patients in your ICUs. Okay, so moving on, today we're going to briefly review the PROSEVA study, evaluate some of the limitations of the trial. Even though it's a fantastic trial, it does, as all trials do, have limitations. We're going to investigate some of the precursors to the PROSEVA trial, which really informed the design and implementation of PROSEVA. Very, very briefly appraise some of the physiologic underpinnings of the prone position. And we have some expert pulmonary and ICU physiologists tuned in, like Dr. Malhotra, Owens, Pedraza, et cetera, who may be able to further chime in on that conversation. And then I'll conclude with some questions and discussion, which is really the whole point of this ATS triple CTF today. And I've put a few questions in my slide in case people remain quiet as we move on. All right, so this is the severe prone positioning in severe acute respiratory distress syndrome by Claude Guerin et al., the PROSEVA study group down here. Published in New England Journal in 2013. I'm just going to cut straight to the chase with the sort of clinching figure that, one, got it the New England Journal publication that it deserved, and also has sort of stood the test of time. So this is the all-cause mortality curve for the prone group versus the supine group. The cumulative probability of survival at days 28, which was their primary outcome right here, and then followed out to day 90, showing durability of response. Just to kind of put this in perspective, the number needed to treat in this trial to see a benefit in all-cause 28-day mortality, which was the primary outcome of the trial, is 6, which is a huge, a low number, but a huge benefit. So just to put that in perspective, the Roy Brauer and the Papazian trials that I previously mentioned had a number needed to treat of approximately 11. So you needed to do this intervention for 11 patients for 1 to see a benefit. So a number needed to treat of 6 is a really impressive figure. This is actually from the supplementary figures in the paper. You won't see it in the New England Journal paper unless you download the supplement, but this actually shows the mean change in the arterial oxygen content over the duration of a proning session. And we'll talk about the trial itself just very briefly in a second. But what I want you to notice is that when patients started out being flipped onto their stomach or placed in the prone position, their arterial oxygen tension was quite low. And then as they spent time in the prone position, it rose quite significantly, nearly 100 points in the first day. This is the first proning session, session 1. And then as they got flipped back into the supine position, back on their back, you can see that the oxygen tension began to fall. And then right as they got flipped back on their belly for the prone session number 2, the oxygen saturation sort of reached its nadir. And that persisted with each intervention, with each day of proning, S4 being day 4, for example. So just really quickly to cover the trial, they essentially, it was done in France. There was one ICU in Spain, but it was essentially ICUs in France. They took patients who had severe ARDS or moderate ARDS, defined as a P to F ratio. Again, that's pressure of arterial oxygen divided by fraction of inspired oxygen, P to F ratio, of 150 or less, and essentially randomized them to the supine or the prone group. And then if they were randomized to the prone group, they basically flipped them over onto their belly in the prone position for an average of about 17 hours a day, with the remaining time spent in the supine position. If they were randomized to the supine arm, they spent their entire time in the supine arm. Otherwise, there were no real differences in how they managed the ventilator. They targeted a tidal volume of 6 cc's per kg, which is by ideal body weight based on Roy Brauer's and et al.'s article from 2000. They targeted a PEEP or a plateau pressure of less than 30, and they titrated the PEEP to maintain typically a driving pressure of less than 15, all of which are independent risk factors for mortality and severe ARDS, and we won't get into those literature due to time constraints. Again, the 28-day mortality was the primary outcome. There were a number of pretty impressive secondary outcomes, all of which were significant: ventilator-free days, ICU survival, survival to discharge, time to discharge, et cetera. The inclusion criteria, in addition to the P to F ratio less than 150, patients had to be on a PEEP of at least 10 centimeters of water, and they needed to have a fractional inspired oxygen of greater than 60%. And again, they had to have a tidal volume of 6 cc's per kg of ideal body weight. Additionally, they planned on intervening, quote unquote, early, which they defined as within 36 hours of initiation of mechanical ventilation and intubation. So if the patient got intubated on a Friday, they got randomized on a Monday, they could not be included in the trial. They had to be included very quickly after intubation and initiation of ventilation. So it is often referred to as early proning. And we'll get to that in the discussion perhaps. So that's just a very basic overview of the trial. You can read a lot more about the trial, and I suspect we'll dissect the trial a bit further in the discussion, but I'm going to move on and just quickly talk about maybe some of the baseline characteristics of the trial, and importantly, how these may have biased towards actually the alternative hypothesis, which is that proning works. So this is the overall table, which is quite small. So I'm just going to blow it up here and focus on some of the important, what I think are important things. Other people may disagree. These are some of the chronic comorbidities that patients had, and it's worth noting that the patients in the prone group here in the right column had lower rates of things that we typically associate with increased ICU mortality. So lower rates of cancer, lower rates of underlying intrinsic lung disease, lower rates of underlying immunodeficiency. And though the numbers are small, they are different. They had lower overall organ dysfunction defined by the simple applied physiology score, or the SOFA scores here and here. And then they had an increased number of respiratory failures due to underlying pneumonias as the cause of their ARDS. So again, ARDS can be caused from numerous things, pancreatitis, trauma, scorpion bites if you're on the island of Madagascar, et cetera. And typically the patients in the intervention group had more respiratory illnesses as the cause of their ARDS as opposed to other illnesses, which may have portended a better benefit towards careful and judicious management of their respiratory system using a ventilator and prone positioning. I think additional things worth noting is that the patients in the intervention group in general, over the course of the study, were probably not as sick as based on these sort of surrogate markers. Less vasopressors were needed in the intervention group. Again, that's the prone group. Less renal replacement or dialysis therapy was needed, and significantly less glucocorticoids were used, perhaps suggesting that the overall inflammatory milieu was lower. Some would argue maybe that because there was less immunosuppression, maybe the inflammation was actually worse. So that last one is up for debate. But all of these things, I think, these different arrows maybe bias the results towards the alternative hypothesis rather than the null. Either way, again, a number needed to treat of 6 is a fairly hard number to ignore. So let's talk about some of the precursors to Prosiva. I can't remember who said it, but someone said something about standing on the shoulders of giants. And I think Prosiva is an example of standing on the shoulders of giants. So this is a really great review article from the Blue Journal, published in 2013 by a very well-known guy from Italy, where he looked at a lot of these precursors. And I'll focus on another another review that was published the following year. But it turns out that the Prosiva study over here on the right, published in 2013, was actually not the first, not the second, not even the 6th or 7th randomized controlled trial of proning. Gattinoni decided to focus on these 5 particular trials, predominantly because he had access to all of their data, because he was involved in all of them. But you'll notice that the first trial was actually published in 2001. It enrolled from 95 to 99. So by the time that Guerin et al. Published the seminal study that we referenced, there was a lot of experience in prone therapy. And it's actually worth noting that all of the trials that enrolled patients in Guerin's study had been involved in some of these previous trials. All of them had at least 5 years of experience of proning patients. And it turns out that proning alone has a lot of complications, which we probably won't go into too much detail. But being experienced at doing that probably helps in terms of favorable outcomes. When people critiqued why all of these prior studies didn't work, one of the critiques was, well, maybe patients weren't prone long enough to see the physiologic benefit, and we'll discuss what those benefits might be in a couple of slides. And that's worth noting, in the first couple of trials that Gattinoni and Guerin did in the early 2000s, patients were actually only prone for less than 33% of the day, which probably suggests that they aren't going to get a lot of benefit from whatever the physiologic changes are that occur in the prone position. Some of the later studies, actually, patients were prone for quite a while, 17 and 18 hours, which is about what Guerin et al. Did. And yet there still wasn't a true mortality benefit in either of these Menchebo or Tacone studies. And then the following year, so this review was written in 2013, right after Guerin published his seminal study. The following year, Jeremy Beitler published this review in Intensive Care Medicine. And I just want to bring this one up for 2 reasons. One, for all of the fellows who are tuned in, this is actually sort of maybe aspirational, but Jeremy Beitler wrote this as a 4th-year fellow at the Harvard Combined program. So for those of you who are fellows, hoping that you can make your mark in the academic world, it is possible. And this is the study. So he basically did a meta-analysis of all of those trials that I just showed you on the prior slide, plus a couple other ones here, Vogenreiter and Fernandez, and basically showed that there's a trend towards overall benefit in the prone group across all those studies, but there's also a temporal trend, perhaps suggesting that from 2001 to 2013, when Guerin et al. Published their trial, that we just became better at treating and managing ARDS across the world. Because again, these studies were done in various different countries, various different ICUs with various different protocols. He further delved into these studies though, and he kind of stratified them by something that we all sort of take for granted at this point, 20 plus years into the management of ARDS, which is low tidal volume ventilation. And so it turns out, and I meant to mention that this isn't actually statistically significant by meta-analysis standards, but it shows a pretty strong trend toward benefit. So he further stratified this based on tidal volume ventilation. And if patients were in a high tidal volume ventilation subgroup within their trial, regardless of when the trial was done, they generally didn't see a significant benefit to prone therapy. However, if they were in a low tidal volume ventilation subgroup, they did see a pretty significant benefit to prone therapy. Now, I would argue that a lot of that benefit is being driven by the Guerin et al. Study with a relative weight of nearly half Nevertheless, the overall statistical significance of low tidal volume ventilation plus proning, sort of as a combined intervention, showed pretty significant benefit and drove the overall benefit of all of the studies just slightly, not statistically significant, but definitely in the direction of favoring prone therapy. So that's kind of a quick overview of the literature. This is a really quick one slide, a few image slide, and then I'm going to pause and let all of the experts who know way more about this than I do weigh in on perhaps why some of these things are happening in terms of proning. So there's this concept of the dorsal caudal lung being compressed when we are lying on our backs in bed for hours and hours at a time, which is maybe why we get up and yawn and sigh first thing in the morning to help pop open those dorsal caudal lung units here that I'm emphasizing with my cursor. And when you're lying in bed 24/7, 365, or for however long you're stuck in the ICU with severe ARDS, this is becoming worse and worse. And these units of lung are unable to participate in gas exchange. However, if you flip someone over and you remove a lot of the cardiac mass and just the general gravitational pull that compresses these dorsal caudal lung units, perhaps you improve the overall recruitment of alveoli or lung units that can participate in gas exchange. There's a number of other things that probably go on since all of these alveoli are not independent, but actually interdependent. There's probably changes in shear forces across the thoracic cage. It probably changes perfusion in addition to ventilation. It likely improves secretion clearance and maintenance, thereby decreasing your risk of developing subsequent pneumonias, ventilator-associated pneumonias, et cetera. This is a CT correlate in a patient, basically showing a patient in the supine position in figures A and B at end expiration. So you can see that all the lungs are sort of compressed down together, and at end inspiration, when you have sort of the most recruited, most openly ventilated segments of lung that you can get. And then the same patient in the prone position at end expiration and end inspiration. And you can just see generally lung volumes are larger, aeration is greater, particularly at end inspiration. And then this was a separate study done in animals that's referenced in a review article that I'll show you in the final slide, which is some additional reading for everyone who's tuned in. But this shows that in addition to changing ventilation, there is probably some degree of change of perfusion and blood flow. And I won't get into the west zones of the lung, even though as a UCSD fellow, I probably should. But it looks like there is more gas exchange blood flow and less shunted blood flow in the prone position as compared to the supine position. Independent of, but also in addition to all of the changes in ventilation shown here on the left side of the screen, as well as some of the other things that I mentioned. So I'm going to pause there and just open it up to the group as well as all of our expert discussants for some questions and some discussion. And I'll just throw these questions on the board in case the discussion stagnates, but it looks like we already have quite a few comments and questions in the chat. So please jump in, Drs. Pedraza, Owens, Malhotra, et cetera.
Cameron, what do you think, you talked about what does early mean? If you go back to your sort of figure 2 showing the separation in the curves, what do you think drove that separation early on? It looks like even on day 1, you know, the patients with proning do better. And I'm curious what you and others think about. Sorry to make you go back through all your slides. But look at that day 1, the curves separate right away. What's up with that?
Yeah, you know, I'm not entirely sure why there's an instantaneous mortality benefit. Because again, this is cumulative probability of survival. This isn't P to F ratio. I think, you know, perhaps it has something to do with the fact that there is a subset of the super severe ARDS patients who, if you do not get sort of control of their oxygenation and gas exchange quickly, other significant sort of things accumulate, you know, cardiac dysrhythmias, hypotension, et cetera, which are probably driven by severe refractory hypoxemia. So that may be the initial separation, is that you're preserving maybe some of that subset of the highest risk patients, though I'm not familiar with literature that confirms that. That's just an opinion.
Yeah. I sort of think the same thing. I wonder if it's patients who their SATs are pretty marginal. You flip them over, the SAT looks better, and you say, all right, we're going to keep them like this, we'll come back tomorrow, versus the people you don't prone and you say, oh, their stats aren't good. And actually, it's hard to figure out why people die in the ICU, but I think these might be ones that we actually would draw care on and say, oh, they're just, their stats are so low. But it's interesting to me. I don't think, I think there's early and late effects from proning. And I wonder what that real early effect is.
One of the other things that, sorry, go ahead, Laura.
No, go ahead.
One of the other, that was a really nice review, Cameron, much appreciated. But one of the other things that I think about in COVID times is that the data is the data, and how we extrapolate that data to fit into our management of patients is a different thing, right? So we traditionally, I'm at the University of Maryland, and one of the, we try and do things in an academic way, and we say, this is what they did in the study, and this is what we're going to do in our patient population with severe ARDS. And COVID really threw a wrench in that. We started noticing that individuals were proning people for longer than the time that was in the studies, because the gas exchange was so much more impressive in the prone position. We noticed that the idea, and I think this was a question that Gurveen Malhotra asked about, how long should we continue proning patients with severe ARDS, since COVID patients are on the vent for a long time. We were noticing just longer and longer times of prone position happening. And the reality is that there are side effects of prone positioning as well. I had one patient who, when I came in onto service, was having a pressure ulcer on her nose from being prone for so long. So these questions are questions that they're not answered in studies, and so it's an interesting thing to pose to the group, that how do we extrapolate data when we're kind of flying by the seat of our pants a little bit by saying, what are we going to do in this patient at this time for how sick they are.
And I would say there's no easy answers, and just how John Williams mentioned, these side effects are happening. Like, should we really be paralyzing, deeply sedating people to keep them? Actually, he's mentioning sort of low tidal volumes as well as the proning. So I feel like, a lot of us have struggled with this, and, coming to some sort of consensus about, what is your cutoff for stopping the proning? So when the P to F ratio is, greater than 200, the PEEP is 10 or less, the FiO2 is less than 60, there's all these things. I know that early in the pandemic, people were like, oh, well, if somebody's no longer responding to proning, some people would stop it at that point, but that seems to have gotten out of favor. But Bob, what's your best practice for when you're proning patients, of deciding when the benefit really is no longer there compared to the risks?
Yeah, well, I guess I went into COVID thinking that proning really had no risks. And I think, like Nirav just said, the number of facial injuries we've had from endotracheal tubes, chin, lips, nose, has not been small, and we've stopped proning on some patients because of the amount of facial edema or skin breakdown. Having said that, I think I'm probably more of a lung protective guy, and I feel like if there are benefits and we're not seeing those risks, I'm okay going, fairly long. Cameron, you may know how long people ended up doing proning in the trial, but we have gone for a fairly long time. I can't, and again, if I keep seeing pretty good benefit, I'll keep going.
Yeah, so in the trial, the IRB was actually written to allow the investigators to prone the patients for a full 28 days, 16 to 18 hours a day, every day for 28 days. In reality, the average was about 4 days. So some patients were proned as long as 12, I think was the longest, 1 or 2 patients for a single day. The average was 4.4 days or something like that.
Yeah, I think our practice has been, and with COVID in particular, longer than that duration. I think we have gone up in some patients probably close to that 12 days or so, usually about 12 days. I think somebody says, look, that was early. We're kind of in a different, the words fibroproliferative get thrown around and we stop doing it. But I think we have certainly taken a number of people 7, 10 days and some even a little bit longer. I'd be curious what other centers are doing.
Yeah,
I think
I'll tell you, I have had that same experience. I've proned longer than I ever have for any other cause of ARDS. And yeah, they end up having more devastating effects than I'd ever assumed possible. One of the things that we've noticed, and I'm not sure if this is due to the proning or not, except that I think we've noticed it primarily in prone patients, is post-extubation laryngeal edema, or just laryngeal edema when we check when we do a cuff leak test, to the point that we're now asking our RTs to do a cuff leak test before extubating. I don't know if anybody else has had that experience, maybe just because of the length of time that we're having to prone them, and something about the position may contribute to laryngeal edema as well.
Oh, Isabel, we've seen the same thing. So, as I was listening to everybody, I realized how much my own thinking about proning as a clinician has changed. So, what's been tricky with COVID for us has been that, when you talk about early ARDS, right, in an intubated patient, what is early in COVID-19? You have patients who are on non-invasive and high flow for already 10 days, 15 days prior to, say, getting intubated. So what does early even mean? I think that for me has been a challenge, right? Because once you do intubate them at that point, where are you in that spectrum of where these perceived physiological sort of changes help you or benefit you? And this has been shown in some studies, and I think personally that my experience has been that at that point in COVID-19, if we are having trouble getting that P2F benefit, the saturation benefit from proning, those patients tend to be the patients who don't do well. And I know there was recently a study that said that, and I think that is just phenotypical expression at that point clinically, that if you're not responding to COVID-19 at that point in the disease process, I don't know if you will. Now, I think people with COVID-19 that did get intubated early on, and again, a lot of studies have shown this, the mechanics are not too different early on in the disease compared to any other ARDS. And I think we have to think about the intervention differently for all of these different patients, right? Like, I don't think we can apply the same principles for these patients depending on how far they have been having their sort of compromise with the physiology. And the other part is also, and I'm sure we're going to get into it, is what about those people who do respond to awake proning? Where does that fit in, right? Those who did respond to awake proning, then you intubate them, now they don't respond to proning. What does that tell you even? So I'll just close out my comment by saying, I think the one thing I did learn at the end of this is that the Ardsnet trial was right, that these midpoint surrogate markers that make us feel better, SATs, P2Fs, all of those nice blippy numbers that turn green, they just may or may not correlate to good outcomes in the end. I think, and I've learned to be okay with it. So if I think I can make my patients survive because they're not going to have a respiratory compromise by proning, I will continue. And then I'm not going to look at 4 days and 7 days. But, if it's just in the process of proning, I'm going to have trouble, which a lot of our patients have had. They get hemodynamic compromise, complications, we stop. So that's the clinician answer, is play it by the ear to make sure you're not causing more harm in the moment.
Yeah, so to answer some of your questions here, Cameron, about kind of what our practice is, what does early mean? So I would say that early means two things to me. One is that we're trying to do proning, and I saw that Dr. Malhotra put a link there for proning, self-proning. So we're trying to use proning before we even intubate. So I would say that we're not even talking about, when we say early, we're not even talking about just right after you intubate, is the PF ratio less than 150. We're really saying, when you come in, if you're in the ICU, we're going to encourage self-proning, and not only encourage it, but we've had to use some sedation to help with self-proning because a lot of patients weren't tolerating it. So we've been using a little bit of dexmedetomidine in patients to try and get them to be able to tolerate self-proning. In terms of once they're intubated, then I think that it's pretty clear that these patients, because we've waited, and I agree, Bob, we're maybe waiting too long in some patients, but because we waited, then once we intubate, we really our backs are against the wall, and these patients are severely hypoxic and really need to be proned right away. And so what we do is we get them on the ventilator. We might use a dose of a neuromuscular blockade to get them in sync with the ventilator, and then we go right on to proning. If we need to use neuromuscular blockade to keep vent synchrony going in the prone position, then we will. But we are trying to not just empirically put everyone on a neuromuscular blockade infusion. In terms of stopping, a 24 to 48 hour period of consistent PF ratios above 150, because what we've noticed is that if we stop proning too early, a day or two goes by and then we're reproning them again. And this has been a cycle in a fair number of patients. And so that's been there too. And then other considerations I think were brought up really nicely in the chat box about weight, patient safety, as well as staff safety, making sure that there's protocols in place. And the other thing that I would say would fit into this other consideration is proning in other parts of the hospital that aren't the MICU. So typically most proning for ARDS was happening in the medical intensive care unit at Maryland. But now that we have patients in different units that have severe ARDS and that they're not used to taking care of them, not just from the physician side, but also from the nursing side, we're actually having to send some of our nurses and respiratory therapists to these other units to help with the proning. So we have to time it. So what are the timings that we're doing this by sending people off the unit? And can we arrange our timing in our unit such that we're not kind of having everyone change at the same time positions? And so these are some pretty practical considerations that have to be thought about when you have patients not in your geographically located in your unit, as we think about doing these modalities across the hospital system.
I think it leads into one of the other core questions that sort of has come up in the chat box of like, how long is too long on high flow? Because as we're talking about that, I've had multiple patients on 80, 90% high flow, they're self-proning, they've been doing it for days, so their back hurts, their side hurts, like they're really tired of doing this. And there's just continues to be a lot of debate about, when to intubate somebody. So they're day 10 of symptoms. So you're sort of hoping that they're nearing the exit and they're going to suddenly start improving. And we've seen lots of those cases. But I really struggle with that about if you let their high flow to be too high, and then when they get intubated, they get very hypoxemic and take a while to help them recover. But I wanted to hear other people's thoughts about what's your threshold to intubate somebody who's able to self-prone and is on, 90% high flow.
I have a feeling you'll get a lot of silence because I think that everyone is maybe a little embarrassed to say what they're doing. I will volunteer and say, I think like everybody, I am very humbled by this disease. I've seen people skirt through. We got prepared to intubate 5 times and then they walk out of the hospital a few days later. Also had people leave the ICU, get down to a few liters of oxygen, come back and need to be intubated. So very humble. But I will say that I put a fair amount of weight on how the patient feels and respiratory effort. And if a patient looks comfortable, I will let them go a very long time, even if they're on all the oxygen. If a patient to me has accessory muscle use, and I do think we're stretching the lungs, I don't have a great way to measure it. I don't have an esophageal balloon, but then I move towards intubation. So I've been weighing a lot more on that clinical judgment, and I'm curious to hear what other people think.
Yeah, Bob, absolutely. I fall into the same camp as you. And that's that many people will come to me at least 5 times a day and say, this person's on this much oxygen. Don't you think we should intubate? And 5 times a day I'll say, but they're sitting there talking to me with a respiratory rate that's 12 and not using any accessory muscles of respiration. And they look comfortable. And if I can hold off, I'm going to hold off. And there's a little bit of a guilt trip that gets put on, right? That it's like, well, if we don't do it now, it's going to be done at nighttime. And do we really want to push it off to the night folks to have to do this, or what are we going to do here? And I think that the reality is that we've got to rely on our bedside exam. And if a patient looks like they're in distress, then no matter what, they're going to go on the ventilator. But if they really feel comfortable, I think that we've all seen patients that have been on a high flow nasal cannula at the highest settings and a non-rebreather when they were exerting themselves. And they were on that for about 4 or 5 days. And then slowly it just started coming down and they went out of the ICU without being on the ventilator. And so I think that those anecdotes are what pushed me to say, no, let's hold off. If we can, we'll hold off, but let's use these parameters. And if the patient becomes tachypnic, if the patient looks like, if the patient says they're tired, boom, that's the number one indication for me. If they say, doc, I'm tired, I can't do this anymore, then that's right. Let's intubate them. But we've got to rely on our bedside exam.
So from an, I think some of you guys know this, that my clinical area of interest is more the airway management, and then mechanical ventilation has become a secondary interest. But so from an airway management standpoint, I have to say that I worry a little bit where we wait for that sternocleidomastoid sign, as I call it, right? That now the SCMs are working, so we are in distress. And I worry because then when you try to intubate, you fall off the curve. And I've seen way too many sort of catastrophic events happen peri-intubation. So when trainees ask me, or if somebody asks me clinically, my clinical decision is threefold. One is, like Nirav was saying, is the patient feeling fatigue? If the earliest sign of fatigue, I'm tired, is I start thinking. Two, from exam standpoint, I have started, and I'm ashamed to say this, but started examining accessory muscles in excruciating detail. So I'm looking here, I'm looking at the intercostals, I'm truly looking at the abdominal motion. So I feel like if I start seeing any sign, not just the true distress, the tripoding, I'm saying any sign where mechanics are abnormal, I start thinking of intubating at that point. And then the third is the timing, like Nirav said. You don't want to do it at a point when you're also admitting to other people, or, as they say, the crisis standard of care falls. It also happens during the day. So I use those three things to make that decision and try not to be at the point where once I paralyze them, I have no room for error at all. So I think clinically that's what I do. But I do want to point out that the evidence so far, at least from COVID-19, is not suggesting that, despite how we are feeling, that early or late intubations are having any different outcomes. I mean, talking about clinical evidence is just not there to steer us either way. Maybe Atul knows more, but every paper I've read, no indication that either strategy is fruitful. I love the silence, though.
I know. But
don't jump in, guys. Don't worry. I won't feel awkward. I'm okay. I also have no shame. No worries.
No, I think you nailed it. So I think we all want more data. And I think that's why, we were reaching out so desperately to New York and then Boston and New Orleans to hear about their experiences, because we were kind of hoping that, okay, they've taken care of hundreds of patients, maybe they can give us the answer.
There's a conversation in the chat box about non-invasive positive pressure ventilation and for patients with worsening hypoxemia. And I'll tell you that my personal experience with non-invasive is that it hasn't been the same as high flow, where I've had people on high flow for a few days or even longer than a few days. My experience with non-invasive has been when I've tried non-invasive, it quickly moves towards intubation. I've not had the success with patients being like, oh yeah, I'll do non-invasive for days at a time. And so I think that, there might be different reasons for that, but I think part of it is that when we lean on non-invasive, we're already looking at the patient that's failing kind of on high flow or on oxygen, and they need the ventilatory support. And so I think that's not been my experience to keep people on for days at a time.
Awesome.
Patients we've had good luck with non-invasive ventilation. I'm also a sleep guy, but it's the person who says, oh man, they haven't let me use my CPAP and I'm on CPAP of 15 centimeters of water. And yeah, I love this BiPAP. I can sleep now for the first time in a week. So
yeah, totally.
But I agree. We have not used a lot of it, very sparingly. And, the V60, maybe because it was mentioned in the chat, you see the tidal volume there, you see the minute ventilation, and you're like, wow, this is really high. And as Viren said, I worry about, is the patient going to be able to keep doing this? So we've been using high flow, and I think that's been very useful, but non-invasive haven't gone there too much.
Yeah, we've primarily used it for patients who are DNI, so they've already decided they don't want a tube, but they're okay with BiPAP. And we've had some successes there, but I get really stressed out when they fail high flow and I have to put them on BiPAP. It's very worrisome. And
There was a question from Dr. Malhotra about the Maryland experience with APRV in COVID. And I guess Maryland, so for those of you that are on the call, so there's the University of Maryland Medical Center, and attached to it is the Shock Trauma Center. And the Shock Trauma Center has Nader Habashi, who is an APRV proponent, big time proponent. And so I'll say that that on the medical center side, we don't use APRV for our ARDS patients because we can't protect the volume, and we're we feel pretty strongly that the volume is important based on a lot of data that's been published. I'll tell you that on the shock trauma side, because one of our biocontainment units is on the shock trauma side, they do use APRV, and the issue that comes about is that as soon as they need to get the patient synchronous or use heavier sedation, which we're having to use in these patients, or use neuromuscular blockade, APRV becomes highly dangerous in those patients because you don't get the release of the small breaths at the P high. And so I still would favor not using bilevel or APRV. I think our experience has been that we have a little bit of a dichotomy of how it's being used over on the biocontainment side and shock trauma versus UMMC. But ultimately, everyone kind of ends up with either pressure control or volume control. That was a good question. I think that there is a lot of controversy around that.
So Nirav, we are in a similar situation. So at Upstate and Krause, right? So the university side, there's Dr. Gary Neiman's lab that works very closely with Dr. Hibashi's lab, right? So a lot of research on TCAV and APRV, but I don't believe they use as much APRV. We here on Krause side, we do use APRV, but not now. We've been using APRV for a better part of the decade, and it's come down to exactly that, right? It comes down to your release breath. But having said that, there is that data, right? Recent trial also after ART, which was stopped because of ambivalence. What was it? Pharmact or whatever, where they showed, again, open lung ventilation isn't working. So we have married the two concepts. So we don't do open lung and go with release breaths of 700. At the same time, we do prevent atelectasis, so we don't exactly go completely low tidal volumes either. So in between is what we have gone for some of the severe ARDS people. Just, again, like I said, ensuring that those release breaths are not those pressure control level 750, 800 cc's, because then we all know what happens. You get all the pneumothoraces and pneumomediastinums, which we've seen so much of.
And just to finish up Cameron's presentation, so he left up this slide so people could see his recommended reading list for those of you who want to know everything there is to know about proning. These are the 6 you should read.
There's plenty more. These are just some good ones, I think. Some hardcore physiology, some meta-analyses, and then some overall just great review articles written by some of the people who were the lead authors or last authors on some of the trials I mentioned.
Cameron, you did a nice job of throwing up a softball and allowing us all to kind of go off on different tangents, but really nice job with the presentation.
Yeah, I love a good discussion. Thanks all for joining. I'm gonna stop my screen share now and turn it over to Dr. Crotty.
He knows how to get people who like to talk and have opinions going. So that was a good start. And yeah, thanks everybody for posting in the chat box. Lots of great questions. I do see a question about Tosolyzumab. I don't know if anybody wants to tackle that one.
So I put an answer in there that said that we're not using it by itself in these patients. Early on, we were with looking at CRPs, and if the CRP was greater than a certain amount, we were using Tosolyzumab. But we're doing it as part of the Remdacta trial, So remdesivir plus tocilizumab in patients, and they get 1 dose or 2 doses based on their clinical response to the trial enrollment. So that's the only way that we're using it right now.
And Bob, your comment on the barotrauma, I've been fascinated by it because I really wondered if COVID is causing just more mechanical disruption to the lungs than other forms of ARDS, mainly because I was already thinking about that because the electronic cigarette vaping device associated lung injury, the EVALI epidemic in the months before the COVID pandemic, that disease state had a lot of barotrauma, so like just a ton of pneumothoraces. And it just seemed to be very different than other acute lung injuries. But what are your thoughts on that?
I'm not sure that I know the mechanism. There was a comment in the chat box that they've had more, in a particular hospital, more chest tubes in the last 3 months than the last 3 years. I totally echo that. Laura, back when you and I trained, you would still see the ARDS patient with like 4 chest tubes because we came in right as tidal volume ventilation was into practice. It's been unbelievable. And the other observation I'll make is that we have had a lot of barotrauma late in disease as patients are recovering. You're getting ready to discharge them and they pop off a huge pneumothorax. So I don't know what it is. Every time I see one, I inwardly sigh because it's going to be a harder patient to manage. Even if you get a chest tube and re-expansion, it does seem to be a marker of injury to me. But I frankly admit I don't understand the underlying mechanism of why we see more in this disease.
And a lot of them are people who are spontaneously breathing too. Like they don't necessarily need to be on mechanical ventilation, which, the mechanical ventilation part, I think, like I was mentioning in comments, reconcile to friability. You know how we're good at coming up with
and waving.
But so much spontaneous pneumothorax on just breathing, high flow, no pressure, nothing, so much.
Yeah, and that's why it was sort of like interesting to me that we had the EVALI epidemic, then the COVID pandemic, and in both of these, we are having a lot of people with the pneumothoraces very early in the disease or very late. So that was another situation where people would go home because they were off oxygen even, and then they would pop a pneumothorax and die, is the thinking. So there was actually a pretty high rate of that in the EVALI ARDS, which is actually a very steroid responsive process as opposed to the COVID ARDS. And as Atul mentioned in the chat box, whether this means that there are very specific cells or enzymes at play that are breaking down the extracellular matrix, breaking down the structure. So I think, the question is, and I don't know the answer, is it barotrauma? Is it somebody making a lot of effort and ripping their own lung? Or is it the cells and enzymes that are being active because of this highly inflammatory process? Or is it some combination of the two?
While we're on this, can I ask a contentious question since I have all the smart people together? So talking about treatment-wise, right? So we've all talked about this works, this doesn't work, that's all great. So what happens after you've done that initial regimen of remdesivir or decadron or ivermectin or whatever else you're using? When that is done and the disease is still continuing, have you done second rounds? Have you tried alternates? What do you guys do? Because there's that third week, right? The infiltrates come back, they don't go away. Some treat for organizing pneumonia, some look for other pathologies, and then some people do another round of remdesivir or decadron. So what do you guys do?
I'm asking people to enter that in the chat box because that was on the to-do list. Is, one of my top questions was, are there any new drugs out there that we can use? And I think part of it is just, we're a year into this and it's still remdesivir and dexamethasone and that's it.
So the steroids in ARDS, oh my gosh, it's like, I don't know what's happening, but it's really blown up, right? And I'm not sure why some of the decisions are being made, but it's really been interesting because I'll come on service and it'll be like, this person's on DexARDS, this person's on DexARDS, they're on high dose and it's just one after another. And I'm like, wait, what do you mean? Where are they in their process? Oh, they weren't doing well, so we put them on Dexa-ARDS. And a lot of people anecdotally are saying that as soon as they put them on high dose steroids, that these patients are doing better. So it's been really interesting to see kind of the application of steroids and ARDS directly to our patients that maybe not, again, are not fitting the demographics of what the trials looked at necessarily.
I do want to raise a concern though. So Nirav, we've actually seen multiple cases of post-COVID organizing pneumonia. And so we've had patients, who went through COVID and now they're like day 24, day 26, because they had a secondary bacterial pneumonia and they're still on 70% high flow. And when you get a high res CT, it actually looks like organizing pneumonia. And then with steroids, that melts away. So I feel like it's going to be really tricky because, there's the old data on steroids and ARDS. And then if you use them late in the disease, that's not awesome. But in COVID, it's such a hyperinflammatory state. And we're seeing all of these, post-COVID inflammatory diseases that, being able to identify the ones that are going to respond to steroids versus not, and hopefully not using steroids to treat late phase ARDS.
Yeah, it worries me though, Laura, and I hear you. I haven't seen as much of the organizing pneumonia per se, but I will say that I worry because a lot of these patients are on neuromuscular blockade as well, and for a significant period of time. And so I worry that they're on the vent for longer, they're on steroids for longer, and they're on neuromuscular blockade for longer. And are we setting these patients up in this post-COVID world of having the critical illness myopathy neuropathy that we've seen and that can be really, truly devastating in some of these patients?
Here, Nirav, this is going to help you have some more sleepless nights. So there's a study that just came out, I think it was in CHEST, which showed that they compared H1N1 to SARS to COVID-19 histopathology. So I think like 90% in all three had ARDS, diffuse alveolar damage, but then 40 to 50% had organizing pneumonia. It's not a small chunk. It's 40 to 50%. And that's, I think, what I'm getting at, right? So now at the third week, when No, histopathology.
Histopathology. Wow, that's impressive.
Specific to COVID. I mean, that's just ARDS, right?
Yeah. And that's the healing. Like if you do a biopsy on patients with lung injury, the healing process of the lung is theoretically organization and organizing pneumonia, right? So I wonder I'll have to look at that study, Viren. That's interesting.
Because you'd want to sort of
systematic review.
Sort of like if it's the infiltrates that they already have, like, when they're intubated and paralyzed and sedated, if those are similar, then you would think that's the original process. What we've been seeing is that you see these new infiltrates popping up like way past the, initial COVID phase, but.
And it's not very different across the three diseases. So like Bob said, and a lot of people are saying in the comments, yes, it is a result of the DAD, but it is still a treatable pathology. I mean, at that 2-3.
I think the question is, do you need steroids to treat it, or do you just need time? I think, in our post-ICU clinic, we see, before COVID, we saw so many patients who were labeled as, organizing pneumonia, some treated, some not, and they all got better, and whether steroids get them better faster, I don't know. But I do worry, there were other things in the comments about, fungal infections and neuromuscular blockade and steroid. I think if you saw Lazarus fail, like me, you're sort of like, I don't really believe in steroids. If you're a new trainee and Dexa-ARDS came out, you're like, go with the steroids. So I think it's a generational thing.
And there was a question in the chat box about fungal infections. I think in general, there is still big questions about these COVID intubated patients or high flow patients getting secondary bacterial pneumonias and also secondary fungal. So I don't know what Nirav and Viren and Bob, your experiences have been.
We've seen it, Laura. We had two patients 2 weeks ago. 2 weeks ago I was up there. We had two patients that we ended up starting on voriconazole for fungal infections. A lot of these patients end up with structural lung disease, and then they're set up, right? They have lines that are in for a while. They have they're critically ill. Their Apache scores high. They're setups for invasive fungal infections, and I think that the steroids aren't helping that.
And besides the structural disease, the immobility, there's also the chronic critical illness, right? 3 weeks in,
yeah.
Unfortunately, you're at risk for pretty much any environmental infection, I'm sad to say, right? I mean, Stenotrophomonas, where did that come from? It's just rough. At that point, if we start seeing any reason to believe there's superimposed infection or another cause, we do a diagnostic check and consider everything. It's just, how many times do you do that testing? Right? Because that's the other part is and I know this is not the avenue for this, but I've been worrying about the cognitive and the financial burden on our patients from this. We call their families, we say, hey, we're testing today for funguses. Tomorrow we say we're doing all this blood work, and it's a struggle. I think clinically it's a struggle to help patients understand it.
And we have
California
9 p.m. on the East Coast, so I'm going to ask our experts to each give us some of their closing comments toward our wonderful 108 participants. And then I want to remind our participants to please take the survey. The link is in the chat box. And let us know what you'd like to hear about next. So thromboprophylaxis, some more on medications, like other supportive care options in ARDS, and also about yourselves, like how are you handling the pandemic? How are you trying to prevent burnout? So with that, if each one of you will give some closing thoughts, and Viren, I'm going to throw you under the bus and have you go first.
I think closing thoughts, and this is taking a page from Bob, is I think we stick to doing what we know. We don't do things just because we are feeling pressure to react. And I think the tincture of time more than ever is important. Just hurrying up and doing nothing, like truly not doing anything unless we are forced to or indicated, but.
Love it. And Nirav, I'm going to pass it to you.
Maybe I'll take that one step further, Brennan, and I'll say, don't forget to do the things that we know to do. And a lot of times when we start focusing on some of these new therapies and kind of, what's out there, what's going on, should we try this monoclonal antibody? Should we try this? Should we try that? We tend to forget just good old fashioned critical care and making sure that we're taking good care of the patient, that we're taking good care of the patient's family. And that we're taking good care of our staff so that they can continue to take care of these patients. It always touches me that people are like, oh my gosh, what you do is very hard. But I'll tell you that it's hard, but it's really hard for our nurses and our respiratory therapists that are in and out of those rooms 15, 20, 30, 40 times a day, taking good care of these patients. So I would say, let's not forget about our good critical care. New therapies, we need to be up on the literature, and we need to look at what the data shows and follow the data and try and apply it to our patients as evenly as possible to change outcome. But I think just going after the next shiny object is probably not the way to do this.
Bob?
Those guys stole all the good thoughts. I agree. I think there's no silver bullet, and we should. But I actually think looking for the silver bullet is a distractor. The only thing, sort of, somebody mentioned in the chat, they said, love how CP didn't come up. I don't know if that's supposed to be CRP. What I'm waiting for, I want to see. I know many people check CRP and ferritin and D-dimer and all this stuff. I don't actually look at it, but I think I'm waiting for someone smart to show how you can use that. Oh, convalescent plasma maybe. But I'm waiting for someone to look at those inflammatory markers to either phenotype or triage. I think there's enough out there for experiment of nature to sort of look at that. And I'm waiting for that. That's the only other thing I'll say I think could be useful in the future.
Awesome. I love it. And I'll just piggyback on that. I think my the takeaway that I think I'm going to walk out of here with and try and focus on is the use of my clinical judgment. I had this training, I have this experience, to look at the patient and, decide, based on, everything I know and been through, what's right for them. And of course, involve them in those discussions and make sure that you are doing what's right for them. So even though I do yearn for the silver bullet, the solution to COVID, which is not coming very fast, I think that is correct. So I really appreciate all of your thoughts. Thank you all for joining us tonight. It's been a really great discussion. We look forward to hearing from you all about what else you would like to talk about in the upcoming weeks. We're planning on doing these sessions about every other week until they're not needed anymore. So thank you again for joining, and thank you so much, Drs. Kaul, Shah, Owens, McGuire, and Dr. Pedraza had to hop off for sort of little emergency, so I appreciated her thoughts as well. So good night, everybody. Take care.
Thank you.
Thanks.